50-year-old male with a history of uncontrolled hypertension. Last seen normal approximately 30 minutes ago by spouse. Patient is conscious but unable to verbally follow commands, but is showing signs consistent with a possible stroke. Mobile stroke unit, please respond to scene.
This is Philip. He's 30 years old. Probably about 45 minutes ago, he had an incident on the couch where he reached for the plate and just suddenly dropped it. We're noticing a little bit of right arm droop, no facial droop, but he's not able to answer any questions right now. He does not have a history of stroke. He does have a history of hypertension. His current blood pressure is 134/98, pulse is 82, blood glucose is 92. We're going to see what medications he's on now.
Can you raise up your arms for me? Can you smile? Can you raise this leg up for me? And hold it up.
On 3. 1, 2, 3. We got a little bump right here. All right, ready?
1, 2, 3, up.
Be still about 60 seconds, okay? Dr. Grata, the scans have been pushed to you.
Okay, thanks. I'll take a quick look at it. So, Mr. Rivers, I'm going to ask you some questions. What's your name? I guess he's not saying anything?
No, this is the same exam I've received the whole time.
See if he withdraws to pain on either side. You feel that, sir?
He's not really withdrawing on the right side.
I'm comfortable with going ahead and treating him.
The total dose is 61.4. The bolus will be 6.1 and infusion of 55.3.
Okay. Well, I'm going to sign off. It sounds like we got everything under control. Just get him bolused as soon as you can, and then you're going to transport him.
This is Park WRN Emergency Department. We have clearance for mobile stroke to proceed directly to cath lab with patient Rivers upon arrival. We'll meet you at ED receiving to assist with transport.
Nationwide, stroke mortality is about 1 in 5. Here in Marion County, it's 1 in 4. And so that was part of our basis for looking at this project, because we want to be able to get that care to them faster. Faster means less disability, or hopefully prevention of death. The thing that makes it different is, first of all, the staff. We have a physician either on board or via telemedicine. We have a critical care trained nurse, and then we have the usual paramedic and medic staff, along with a CT tech. When a patient or family member calls in and says, I'm having a stroke, or my family member's having a stroke, EMS is dispatched like normal, and so are we at the same time. The largest differentiator of this vehicle from others like it is the CT unit at the back. It's the same version though that we use in the hospital. We have one in the OR, one in our neuro critical care unit. It's just a more mobile version, and it's mostly for head and neck work. For the CT unit to function properly or function at all, the truck has to be level. And since many of our streets and locations around the city are not level, we had a leveling system built onto the truck so that it has the ability to level itself. It's all automated. It's really cool. This device, which is made by Max Life, and it is a telemedicine unit. There's a camera here, there's a camera here, and a third camera right there that all, so if the doctor for whatever reason wasn't able to come on the truck with us, they call in, we call in, and they can see the patient and everything that's going on in the unit. They can use these different cameras, and they can shift them back and forth wherever they are. Their iPad, their iPhone, sitting at a computer, and they can zoom in on the patient, zoom out, look at different angles, and help make determinations as far as the patient care goes. It took a lot longer than we expected. This process has been almost a full 3 years. It was in excess of $1 million, and part of that included is not only the vehicle and the equipment itself, but also operational costs for the first year. Up here is an electrical nightmare. We have dual redundancy set up for internet and Wi-Fi, so that if, for instance, AT&T is not working, we can use Verizon and or vice versa. Whoever has the strongest signal strength, that's who we'll use, and the system's set up to be able to switch back and forth on its own. This would be rumor, but we've heard that people who have already rolled out programs like this at their facilities have already put in requests for more than one unit. This is clearly a collaborative effort. Indianapolis EMS, our physicians, the hospital, ITIS, radiology, it's very collaborative, and we couldn't have done it on our own. It definitely took the input from everyone to do this.
We recognized that there was an epidemic of stroke in this community. Over $200 million in cost, tremendous human suffering.
About 800,000 Americans will suffer a stroke this year, and we think about 3,000 people within our own community here in Monroe County will suffer a stroke as well.
So in stroke, time is brain. At the onset of a stroke, brain cells begin dying, 2 million per minute. The clock is ticking.
We have created the best way to deliver stroke care to the people of Rochester.
We couldn't simply wait in the emergency room for the patient to come to us. We had to bring the emergency room to the patient. The way to do that is to build a mobile stroke unit. We need to begin to bust the clot in the brain as soon as possible. And the best way to do this is to take the mobile stroke unit right to the patient's home and give them the life-saving clot-busting drug IVTPA 40 minutes earlier than they would get it if they were transported to the hospital.
The team on the mobile stroke unit is our stroke SWAT team. It is an EMT, a paramedic, a critical care nurse, and a CT technologist whose only job is to treat stroke patients.
Time is brain. The sooner we can get them treatment, the better they'll do. Brain cells are saved, there's less disability from that stroke, and patients will do better.
Once this ambulance rolls up, our stroke SWAT team gathers the important history that they need. The patient is taken inside the ambulance, blood is drawn, labs are obtained right on the ambulance. A CAT scan is done. All this information is then transmitted to stroke specialists at the main campus. The nurse on board and the stroke specialist determine whether this patient qualifies for the life-saving medication, TPA. What we rely upon most to make a decision is CAT scan imaging. And depending on whether somebody's having an ischemic stroke, where blood flow is blocked to the brain, versus a hemorrhagic stroke, where blood is leaked out into the brain, treatment options can be very different. The CAT scanner that's equipped inside the mobile stroke unit allows us to make those decisions right at the patient's home and to figure out what treatment the patient needs.
And studies have shown when other communities have embraced the idea of a mobile stroke unit that they can reduce the time to treatment by 20, 25, 30, 35 minutes.
So time is saved not only in the patient's driveway, but when the patient arrives in the hospital. The mobile stroke unit is very, very new technology. The first mobile stroke unit in America was launched 4 years ago. There are only 12 in the country right now. There's one in New York State in New York City. So we are one of the smallest cities in the entire country to launch a mobile stroke unit.
And it is incumbent upon us as vascular neurologists, neurosurgeons, primary care providers to inform our patients what to do if they think they're having a stroke. And that can be any of a number of symptoms, but the hallmark is that these findings are usually of sudden onset, and they're usually characterized by weakness or trouble with speech or balance. When an individual is having any of those symptoms, either they or someone near them should call 911 first and say to the dispatch officer that I think I'm having a stroke, or I think that my loved one is having a stroke at this moment. That sets the whole thing in motion.